Good evening, everyone. We seem to have lost our second host, Mr. Murray. I don't know what happened to him. He fell out of the picture. Welcome to our monthly podcast. As you all know, we run this as a informal conversation, and I'm so glad this evening that we're being joined by my good friend and sister, Dr. Mildred Williamson. This month, in fact, last week, is the 40th anniversary of HIV/AIDS, and so we thought that Dr. Williamson was a perfect person to have on the podcast. She is really one of the national leaders for HIV and has played an important role not only in Chicago, in our area, but on the national level, serving on the President's Task Force for HIV, leading a number of national organizations around AIDS, and also for a time serving as the key person in the state for HIV, the state of Illinois. I'm getting a text message from Marcus complaining about the state of his internet connection. So now he's having to jump on a cell phone. So he'll join us when he can. So first, Mildred, so I can't ask you the kind of silly questions Marcus usually asks, which are about what baseball team you like and that kind of thing. But I will say this to get us started. Dr. Williamson has joined those of us of gray hair in the role of being officially retired. She recently retired from heading the Core Center, which is our specialty HIV center for county health, for Cook County Hospital. So how's retirement so far, Mildred?
I'm getting the hang of it. It's all right. And thanks so much for having me.
Oh, it's our pleasure. So let me ask this. Let's start off with just some notion of what it was like 40 years ago. So that's 1981, when HIV began to appear as a disease. Can you remember what you were doing and what the thinking was back then?
So in 81, I wasn't quite in a career of public health, but I absolutely remember that year and they marked 1981 because I think it was June 1st, if I'm not mistaken, the MMWR came out with the headline article on these unusual cases of a very rare pneumocystis carinii cancer of, I believe it was 5 what turned out to be white gay men in Los Angeles. Since then, we've learned, different scientists and laboratories and so forth have kept tissue of people who've, over the decades, who've died from unknown causes. And they've gone back and tested some of those tissues. And I think the earliest I saw was 1959, where someone who died from unknown cause, they kept their tissue and tested it, and it was from HIV. There's a book that came out a few years ago called Tinderbox that traces what they would say the origins of HIV directly to colonialism and the connection between human beings and primates in, let's say, most likely 4 circumstances at the turn of the century. That is the 19th to the 20th century.
So I remember in the early 80s, there were lots of rumors and concerns, especially in the Black community, about the source and origins of HIV.
Yes.
Many people thought it was invented by white folks in the lab. Yes. I've always maintained white folks aren't nearly as smart as we think they are. So I'm always a little hesitant about some of these conspiracy theories. But maybe you could explain the basic notion within that Tinderbox book, because I thought it's a very excellent book. I'm blocking it. I'll try to look up the author's name.
I think I can find it. If you'll bear with me, I'll find it and I can share it with you. It's that book is written by Craig Timberg and David Halperin, and it came out in 2012, and it's called Tinderbox: How the West Sparked the AIDS Epidemic and How the World Can Finally Overcome It. Okay. So welcome, Marcus.
We've been joined by Marcus.
Guess who's back? They're doing construction in my neighborhood. My internet just went out. I'm happy to be here. Back again. Hey, I know you all started, but you know I'm superstitious, so I have to do my one thing with Dr. Williamson before we get started. So, Dr. Williamson, I know you're a diehard Bears fans like me. So, what you think about the Justin Fields?
I was shocked. I have never seen the
Acquisition?
Bears go out and actually look for someone who could be a marquee quarterback. Let's see how this goes.
Especially it looks like us. And the second thing, I want to congratulate you on your 50th wedding anniversary this week. That's Black
Thank
love,
you.
like 50 years. That's real. And often, you know, as Black folks, we don't see that symbolism of love with our people. So for real, like I'm proud, I'm happy for you, and I look forward to getting 50, you know, myself. So back to the show. I
Fabulous.
just wanted to say that.
Thank you. Thank you.
But no problem. And I heard you all talking about the conspiracy theories around HIV, you know, and I remember being, I don't know, 16, 17, 18 when HIV came out. My generation and my peers, we did think it was some man-made conspiracy type theory disease until we saw the impact in the Black community. And then we didn't care whether it was man-made, whether it was from Africa or wherever the conspiracy said it was from. We just cared about that it was being transmitted through unprotected sex, you know, needles and things like that. So go ahead, rock on, Dr. Williams.
So a couple things about that. I think one of the things that it's a lot of things. What, as they say, what goes around comes around. So as you know, there's all kind of conspiracy theories associated with COVID-19 and all of this, and I can draw some parallels. But one of the things that I think did not help the situation was the original framing of those early cases and then naming the disease based on people's individual characteristics as opposed to or some behavioral thing that people do as opposed to something more scientific. The very first acronym that was put out, I mean, by scientists, was GRID, gay-related immune disorder. So right away, a message was sent that this is something that only happens to gay men, because it didn't have a gender on it, but gay men assumption. And because those very first cases that the MMWR identified, which is, the official CDC scientific newsletter, were white men, again, it confined a thought process that engages humanity or science. One more thing I want to add about the conspiracy theories that did not help. There are some researchers based in New York, Desjardins, I think another one is Friedman. Their area of research is substance use disorder, opioid addiction in particular. And some of their research showed that there were people, mostly people of color, that had actually died of AIDS, when we learned died of AIDS before 1981. And they argue that if that population had been paid attention to better with services, programs, outreach, and so forth, we might have identified HIV as a new outbreak earlier than 1981. But because that population was, highly marginalized at the time and basically still is, that got very little attention, and it's still a problem today. So all of those things fueled into, the things that happen with people's imagination about conspiracy theories. And of course, I'd be remiss if we don't recognize or at least acknowledge actual atrocities that we know, proven, documented, that happen to Black people in the healthcare system as well as in research. So I think all of those things contributed to the various conspiracy theories that ran around.
So 40 years into this disease, we're talking about what, 32, 33. I mean, this is an undercount, but officially 30 to 35 million people have died from AIDS globally, is I think around where we are.
Right, and there are 38 million people around the world living with HIV right now.
And how many of those have appropriate treatment and how many don't?
Well, that's a good. So 38 million people worldwide living with HIV. And to this day, 40 years into the epidemic, only about 25 million people have regular access to antiretroviral therapy. And the difference maker with living with HIV as opposed to dying from AIDS is regular treatment with antiretroviral therapy. So that is the world. And if you look around the world, where the people are who don't have access to these medications, life-prolonging, game-changing medications, they're the same countries, unfortunately, that have very little access to the COVID-19 vaccine. So if you talk about the global South, Sub-Saharan Africa remains the main density place in the world with HIV cases. You can look at that same region of the world that doesn't have sufficient access to COVID-19 vaccines. In this country, there are about 1.2 million people living with HIV. We have definitely had a decline in new infections, and around the world, there's been a decline in new infections. And the main reason for the decline in new infections is because of the people who do have access to regular antiretroviral therapy. And if they're taking it as prescribed every day, then they reduce the amount of virus in their bodies so low that it's what's called undetectable. And we now know if a person reaches an undetectable level of virus in their body, their ability to transmit the disease sexually goes down to zero. So it is, you can see that in this sense, treatment is prevention. The majority of HIV cases that are passed from one person to another are passed from a person who doesn't know that they're HIV positive when they have sex with someone else and not on therapy. If a person is on antiretroviral therapy, taking it every day in medical care as they have a right to be, should have a right to be, they will not pass HIV by sexual contact.
So I'm sorry, go ahead, Marcus. He's frozen. So when we think about HIV as an example, this is an example of that has lots of parallels today. So one thing I will point out, so as a retired physician, that HIV has been the major pandemic of my career as a doctor. COVID came after I was already retired. And I think part of the problem people have is that, especially younger people today, is that this is not a once in 100-year event to have a pandemic like this. Mm-hmm. And so I would say that many of the so-called lessons that we should have learned from HIV, we haven't learned. Let me give you an example of another problem. Syphilis, old disease. Mm-hmm. But during World War I and World War II, the rate of syphilis in American men was so high that people, the government felt it jeopardized the ability of the army to actually fight. It's an interesting thing. Mm-hmm. And there was a campaign to eliminate syphilis, which we could have done, mm-hmm. just like we have the ability to eliminate tuberculosis. Mm-hmm. And I know today people are calling for the elimination of HIV by, mm-hmm. I think, 2030. Do you think that's a realistic goal?
Well, here's the issue. In fact, there's a whole campaign. It's called 90-90-90. And the U.S. strategy is kind of modeled similarly on that campaign. And it goes like this, that originally by 2030, 90% of people should be diagnosed. That is, 90% of people living with HIV should know their status and have their test results. And of those who are tested and positive, 90% should be on treatment. And for those on treatment, 90% should be virally suppressed. And we are definitely not there yet. In the world, about 59% of people living with HIV, the UNAIDS and World Health Organization is noting as virally suppressed. We have some similar kind of numbers in our country. And this issue of not being virally suppressed, not being on treatment, not knowing one's status is still an issue, even though I don't want to belittle the good news of a declining number of new infections. The problem is, of those new infections that do take place, 36,000 every year now in the United States, used to be 40,000, 50,000, now it's 36,000. Let me put it this way. The last time white people made up the majority of people living with HIV in the United States was 1993. So the majority of new cases today, even though we have declining numbers, are among African Americans and Latinos. And among women, it's very low, but if you look at all women across all nationalities, the number one group with new infections are African American women. The greatest news, I would say, here and elsewhere in the world is the near elimination, and Cuba has already done it, of mother-to-child HIV transmission. We are definitely near elimination. I can tell you in the Cook County health system, there's not been a new positive case of mother-to-child transmission for the last 20 years. And every year we have it, on average, about 50 pregnant women who are living with HIV that are served by our system, deliver their babies, and they deliver their babies HIV-free.
So that's some interesting numbers you're giving us, and let me again draw some parallels for us to consider. So to think that what started off and was identified as a gay white disease hasn't seen a majority of white people in the United States since 1993. What that means, and even though the numbers have been getting better and better and better each year, what that means is that this is still running rampant in our community, in the Black and brown community.
Yes.
And this is the thing that concerns me, because as it gets concentrated more and more in our communities, it tends to get less attention and less resources.
Yes.
So the resources for prevention relative to the need has decreased. I'm not sure what's going on in the care arena that much, but this is what really scares me about COVID. Even though we have what appears to be effective vaccine for the moment, unless a new variant comes that can escape our present vaccines, I don't want to be in a situation in 3 years or 5 years where the number of people that are dying, that are getting COVID and dying from COVID is low. It's only a few, but then all the 10,000 people in the country, now we have 600,000 people in the United States that have died from COVID.
Right.
But I don't want whatever that low number to be all Black and brown people.
Right.
So one problem I think we have, just as ordinary human beings, because these numbers are so huge, is it's hard for us to compare the relative weight of these different pandemics. So in 40 years, HIV, again, these are all undercounts, but has killed 32 million people. In 15 months, coronavirus has killed 3.8 million people in 15 months.
Yes.
So even if we curb how many people get COVID and how many people die from COVID, it's still going to be concentrated among Black people, brown people, poor countries, poor people. And we could still be, even at this high rate, we could have far more than the HIV pandemic has killed. We could easily get above 30 million real quick, a year or two.
Right. And just one other thing I will add, of those new infections that are taking place, we're talking about people, the main age range of new infections are people aged 20 to 29 years old in the United States. You know, and when you look at people who've become infected, I don't want to make a blanket statement, but tends to be multiple vulnerabilities, you know, that have never been addressed, multiple traumas that people have lived through, multiple episodes or patterns or chronic abuse that they've been through. Again, I don't want to make a blanket statement, but when you have a situation where we had a 14% decline in new cases in Chicago. So about 36,000 people in the state of Illinois living with HIV, and of that number, about 24,000 or a little less are living in Chicago. You know, at the end of 2018, it was only 734 new cases. First time it was under 1,000 cases, and since I've been involved, and so that was the lowest number since 1988. But of that number, 55%, Black young people, and when we think about what's going on at the same time, incredible challenges with public education, living wage, employment stability, housing, all those kinds of things. People who are marginalized in those basic areas, of which that's disproportionate in our city amongst poor people of color. This is where those vulnerabilities come together to be a host, actually, for HIV to travel.
So Doc Williams, let me ask you this. What do you think the impact in terms of education and awareness and the Magic Johnson effect has had on HIV in terms of people forgetting about it?
Well, first of all, I'm glad you came back to that, because I would say there's several things that happen. I don't want to put everything on what I'm about to say, but the diagnosis of Magic Johnson was like lightning, I would say, in the Black community. Because I think, let me just say this. Not only his diagnosis, but how he has handled himself at that time and since, in terms of being an ambassador in HIV awareness, prevention, and advocacy for treatment. So when Magic Johnson tested positive in 1991, there really was only one, maybe two, of what I talked about earlier, antiretroviral drugs approved by the FDA for use. The very first one was AZT, that was approved in 1987, and there were maybe one or two others at the time. Today's HIV medications is one pill a day with usually 3 medications in that one pill. And they attack the virus at these different points of entry and exit, so that it stops the virus from replicating, reduces the amount in the body, thus preserving the T cells that the virus would have destroyed if a person was untreated. So when Magic Johnson tested positive in 1991, and his public reveal of it and the way he's handled himself since, what that did was say to people who look like you and me, oh, this is real. It could happen to me. The other thing about Magic Johnson, really important, Magic Johnson was involved in the early clinical trials that led to the proven therapies that we have right now. And his doctor was Dr. David Ho. So that's like, Dr. Fauci, basically, insofar, because it was Dr. David Ho who was the principal investigator of the study that proved this third category of drugs, protease inhibitors, what is made the final band to construct what we would call highly effective antiretroviral therapy. So that's that third drug category that is, usually the combined drugs in the one pill. So Magic Johnson's, timeliness and proximity to the best treatment and research and so forth, but also his own personal announcement, sharing his humanity with everyone else, and then going on to this day to remain an advocate for everybody else in the world who needs that. That was a game changer. There are others who've since, there are others. I don't want to just put it all on him, but for the Black community, that was a game changer.
So what about the impact now, though, in terms of on the streets? Sometimes you hear, "Well, Magic lived with it. I'm not worried about HIV. I could pop a pill." There's no health education or awareness anymore. It's like around 2005, 10, the world got HIV fatigued, and we just forgot. We're chalking it up like syphilis, gonorrhea,
right.
a simple STI.
Right. So two things: while there's a decline in HIV cases, every single reportable sexually transmitted disease is increased, including syphilis, congenital syphilis. Every one of them is on the upswing, with the exception of HIV, interestingly enough. One of the things that has happened that may not have been intentional, but this is where we are, because the medications work so well for those who are taking them, especially if you don't have any other morbidities, you can absolutely live a long life. And there are patients that I met years ago when I first started working at Cook County, at the time, Cook County Hospital, now the Stroger Hospital, Cook County Health System, who thankfully are still living today, and they're on these therapies. They were on those earlier clinical trials, because every one of those clinical trials, our program was a part of those clinical trials, all of them. Same thing with COVID-19. So because the medication works so well, that has definitely had some complacency. But there are two other things I think we have to talk about. And that is, we know treatment is prevention, but we now know of another prevention tool that's not a condom that anybody can just pick up anywhere and get. It's a prescribed tool. It's called PrEP. And so it's a pill with two of those medications in it, that if a person who's HIV negative goes on PrEP, has unprotected sex with someone who's HIV positive, they can prevent themselves from becoming HIV positive. There's even a treatment called PEP, same thing. If a person within 72 hours of sexual contact with someone living with HIV, you take the PEP medication, you can prevent HIV from developing in the body. Now, here's the thing about that.
What's the side effects, though?
To my knowledge, the side effects are minimal, very minimal. I think there's one drug maker, and I'm sorry, I'm blanking on the drug maker. One of the drug makers that makes this medication, their clinical trials did not involve women. So we don't have definitive evidence for how this hurts, harms, or helps women. But the other one, the brand name is Truvada, and I'm sorry, I'm blanking on the scientific names. The other one, men and women were involved in worldwide clinical trials. That medication works, but you got to have a prescriber. You have to go to the doctor every 3 months. You have to be tested every 3 months. It doesn't protect against STIs. So, if you're engaged in a relationship with someone sexually, you still have to protect yourself against that. But the big thing about PrEP is, unlike HIV medications, which even if you live in Mississippi or someplace where they didn't expand Medicaid, or maybe a very poor health safety net system, the Ryan White Care Act program is all over the country and in all the U.S. territories. So if a person is living with HIV, if they go to a medical provider and the services are covered by Ryan White, you can get your medications. There is no program that pays for PrEP medication unless you have insurance, regular health insurance, or if you have Medicaid. And as you know, this is a disease that disproportionately affects young adults who are childless in these states around the country that never expanded Medicaid under the Affordable Care Act. They're not going to have a source of payment for that if they don't have health insurance. So, and CDC doesn't cover PrEP, even though that's our prevention agency. Ryan White doesn't cover PrEP because their services are for people who are already living with HIV. And we don't have enough marketing PrEP awareness. The very people who need these prevention tools, many of them have never even heard of what we're talking about right now. They may know about condoms, but they may not necessarily know about these medications that they can take. And if you think about a person who may be in a relationship where they don't have equal rights within that relationship, or there may be abuse, or there may be sexual assault, if you have access to something that you can control to protect yourself, this can be helpful. And for a lot of people, they don't even know about these tools and their availability. So you're right. There's been a certain amount of complacency about this because the medications work so well for people living with HIV. But we're talking about marginalized communities now, just like COVID-19. Now people are talking about, well, maybe we should go door to door and start giving the vaccine out to people who live in these communities. We have to take a drill down approach to reach these marginalized communities, because those are the people who actually need the information we're talking about, the tools we're talking about, and access to appropriate health care that we're talking about.
So Doc Murray, Doc Williamson, speaking of COVID-19, COVID-19's been out, with this version of it for what, about a year and a half, 2 years? And it's the lowering of the immune system, and we have a vaccine. HIV has been around for 40 years. It's also a version of lowering the immune system. Why no vaccine? Why no treatment? Is it just a money thing? Like, it's better to have people suffer from HIV to make money off insurance, so insurance companies can make money and things of that nature, or what? What's going on?
Vaccine research is definitely going on and has been going on. For HIV. I just think, and I'm not a microbiologist, but I think it's harder to produce that than the vaccine that was produced for COVID-19. That's what I'm looking at. Because is that okay? Because the activity around research for HIV vaccines, that's in Dr. Fauci's shop. They are doing that, but it took us, it wasn't until, so let's put it this way, Marcus. Let's go with the CDC's identification of AIDS in 1981. We did not get effective treatment, antiretroviral therapies, and with the medications we've been talking about, until 1996. So that's a long time. And it wasn't until protests took place around the world that more than 8% of people living with HIV in the world got access to antiretroviral therapies. So the science takes a while.
So we're talking about, we've certainly spent more money, a lot of money trying to develop an HIV vaccine. The COVID vaccine, frankly, let me be blunt, we got lucky. Now, a lot of the basic research for the Pfizer and Moderna, for what we call the mRNA vaccines, this is groundwork that was done decades ago, but we still got lucky. So these virus families, if we know, virus is just a big category of a microorganism. So, for example, look at our ordinary seasonal flu viruses. That's what the reason why we have to take that vaccine every year is because the flu vaccine changes so quickly, and every year we got to figure out what strains are going around and produce a new virus. This is going to be a crude description of what goes on with HIV. I'm not a virologist, but this is my crude understanding, is that the nature of the HIV virus, the things that we normally look at to make a vaccine. What do we do with COVID? We sort of try to look at projections on the outside of the cell to make a vaccine to block its ability to enter human cells. That's essentially what happens, or to prevent the virus from actually reproducing in the cell. That changes so fast. We have not been able to develop an effective vaccine. Will we ever be able to develop one? I'm not at all sure. There's controversy about that. But the short answer to your question is the HIV virus is profoundly different than the COVID virus and the coronavirus family.
I'm not buying it, Doc. I'm not buying it, because if it's a lowering of the, so I want you to hear the confusion in my voice and then understand what people think, regardless of that color and race. If it's the lowering of the immune system, and HIV has been around for 40 years, and we don't have a sensible treatment or a cure, but COVID has been around for a year and a half, and we have a vaccine, and there's been a lot more money, time spent on HIV research. Yeah, why should I even trust the American government or the medical system to deal with both? You see what I'm saying? It's like the government is picking and choosing what they want to assist people with and what they don't want to assist people with. So let's back. And last thing, you could throw cancer in there too. Okay.
So let's back up. So one thing that I personally believe is that the American government does not act in the interest of our people. So to me, that's not a debate. I'm not trying to debate that.
I'm on that page.
So let's look at some basic stuff. All of us can easily, I'm just going to give this as an example. We can easily figure out if someone has a fractured bone. Most people don't even really have to take an x-ray. We can figure out sort of, you got your bone, your thigh bone is broken. But what breaks your thigh bone can vary. Your thigh bone could be broken because someone took a hatchet to your leg. Your thigh bone could be broken because someone took a baseball bat to your leg or someone shot your leg. Now, the protection you have to prevent that kind of fracture differs. If it's a baseball bat and you're able to put some shin guards up, you may prevent that fracture. On the other hand, a bullet, you may not. That may be harder to prevent. So let's make a distinction between what kind of virus is causing damage to the immune system. The fact that they all impact the immune system isn't the important thing. The point is, how do they impact the immune system, and what kind of protection do you need for that specific kind of threat? So what I'm saying right now is that the threat by these different families of viruses is different, and it decides whether or not it's easy or harder, relatively speaking, to make a vaccine. And don't forget, the vaccine is one of the things that we have. It's one of the better things that we have to defend against it. I'm gonna leave cancer alone for a moment. That's a whole set of different diseases. So in human beings, like if you get a headache, you can have a headache because you didn't have enough sleep. You could have a headache because you're hungry. You could have a headache because you've been looking at the bright sun. You could have a headache because you have a brain tumor, or you could have a headache because you have a stroke. You can't just say they all cause headaches, so they're all going to have the same diagnosis and treatment. That doesn't make good sense. What we have to understand is the conditions that create these pandemics, that allow it to spread around the world and kill millions of people. We know conditions that cause that. Mildred mentioned some of them earlier in terms of colonialism, the breakdown of borders between humans and animals. There are lots of conditions that do that. the ability to fly across the world in a couple of hours. These are all things that make these pandemics easier to spread or harder to spread. The key question is, what mechanisms do we have to put in place to first slow down and eventually eliminate these threats to human life? And that's the thing that we have to come to grips with. And so just because we're successful with one problem like polio doesn't mean we're going to be immediately successful with a new problem like COVID-19 or an old problem like HIV.
That was a nice soliloquy and a very good answer. Now I want to ask the second part of my question, and I'm glad you threw it out there. So since we had, and I'm gonna repeat what you guys said. So we have PrEP, we have PEP, we have clinical trials. So what's the deal with the naturalistic perspective, like brothers like Dr. Sebi, who have allegedly found cures for HIV and AIDS through natural remedies such as diets, food-based medicine? Why has that been pushed under the table, and why have we not looked at that in science since we've been around for 40 years? It's been around 40 years, and millions and billions of dollars spent on research.
So again, I want to be clear what I'm talking about here. The brother you mentioned, Dr. Sebi, is that how you say his name?
I don't know. I get confused sometimes.
Okay, well, it doesn't matter. So the first issue, anyone who says they have a cure for anything, there's a way that we generally agree upon. You have to prove this. Mm-hmm. There haven't been trials on this. So that's one thing. Now, are you asking me, does science sometimes ignore unorthodox approaches? Yes. If you understand the history of science, this is frequently the case in science. So I'm not trying to defend that kind of attitude. What I will say is that we have not seen in the whole world, we have not seen a successful trial with some of these more naturalistic for HIV. But be clear, there's nothing magic about this. Don't forget, many of the medications that we use in the world today are based on quote unquote naturally occurring substances, like the Dioxin, for example, a basic medication that we give for people with heart failure. This is basically a plant. It's a plant origin. Or aspirin also comes to us from plants. So I don't try to say that sort of things that occur in nature don't have, some of them have medicinal value. The key point with that is, can you isolate what is the most active ingredient? Can you produce it in a way that you know that if you give me one dose, it's the same as the dose I'm going to take tomorrow? And then can you rigorously show through clinical trials that it's safe and effective? So that needs to happen no matter what the source of the so-called cure is. But I personally am not against looking at some of these theoretically natural cures. The last thing I'll say is the science behind nutrition is very, very complicated. I don't think we have a good handle on it. It's not that I don't think it's important. It's just that we have not had a good way to study it.
I'll just add one thing to that. So there are two major HIV disease progression studies that have been going for quite a while. One is the MAC study, and that's the study of HIV disease, HIV disease in men. And the other one is the WISE study, which is the study of HIV disease in women. MAC has been going since 1983, and WISE has been going since 1993. Never mind the 10-year difference between these studies in terms of men and women. However, the reason I'm mentioning those is because over the years, those studies also have produced lots of papers about nutrition, about the digestive system, all kinds of things associated with living with HIV, various comorbidities. And if anyone wants to look at any of those things, any of those papers that have been developed based on those studies, that stuff is available. And there is evidence about the role and impact of nutrition. But that's not instead of medications. That's along with medications.
Now, I definitely agree with both of you. First, let me just in my street side debate by saying this. Most clinical trials are sponsored by the federal government or pharmaceutical companies. Those are the two entities that are highly opposed to any natural plant-based type of healing because it's less cost effective and people could probably grow the plants themselves and they would lose their money in their summer home. So we could debate that on another show. But Dr. Williamson has brought up some excellent points. When I was younger, I was a little apprehensive about clinical participating in clinical trials and clinical research as a Black man because I didn't know anything. And a lot of times, Black folks are reluctant because they don't know or understand. Clinical trials are very, very important when you're talking about healing our community. But I will say this. Clinical trials need to be developed, implemented, and ran by us. We need to take the FUBU approach. And I think if we understood the importance of clinical trials, we wouldn't have that male and female gap that Dr. Williamson was just talking about. And we would just take just a more hands-on approach in healing ourselves as well as helping the government and the healthcare system. I don't know. It's just my thought.
No. Here, I think is a lesson that we should have learned from HIV, but we didn't very well. In the years that it's taken us to get effective treatment for HIV, the couple of decades it took us to get to that point, there are other things that I would argue the ordinary person in the street already knew. Because when AIDS first came, it was basically, for most people, 99% a death sentence. And so what happened? So we said things that shouldn't have been earth-shattering, but to many white medical establishment people it was, like, you'll be healthier if you have a house to live in instead of living in the street. Mm-hmm. So for people living with AIDS, we said we got to give them housing. Mm-hmm. It would be better for you if you are infected with HIV and you have diabetes, that we treat your diabetes, that we treat your high blood pressure. It would be better if you had good mental health services. Mm-hmm. It would be better if you had a job that gave you, because we didn't have at that moment very much pills that could help you. And so this lesson, which happens in so many situations, to me, it's basic common sense, but specifically about HIV. So what we learned with HIV is, in order to effectively prevent and treat and care for people that were infected with this disease, no matter what stage in those 40 years, you have to treat people like they're a human being. You have to recognize their basic dignity and respect as a human being, and you have to provide them with what every human being needs to live, whether they're infected with HIV or not. And those people did better at every stage. So to move to the point where we have some pills that will work, if we just go to giving out pills, I'm going to tell you what will happen. Those people that get pills and don't have a job and are living out in the street, etc., they're going to die earlier. They're going to have trouble taking their pills. They're going to be in big trouble. Mm-hmm. So I think that part of the lesson we have to learn. The same thing with COVID. It's not just that, most people that got COVID didn't die. Most people, fortunately. But if you were already working 2 or 3 jobs and you already have diabetes and you don't get a chance to rest and you come home with it and spread it to your family, these are the communities that have really suffered from COVID. So these lessons are basic. They're human lessons, and we keep repeating them over and over again. But certainly as people of color, we know what we need to be healthy, and we have to fight for that.
I just want to add one more thing. The activism with HIV itself has been and still continues to be a game changer. So it's interesting. The Ryan White program is now 1990. It's since 1990, and in this country, I can't think of anything else that has the kind of funding that this has. Housing assistance, utility bill assistance, all the things that Dr. Murray talked about, case management, substance use disorder treatment, mental health services, respite care, all these things are covered. under the Ryan White program, and highly important is the cost of the medications themselves. But another thing, and it's activists that push for that. And from 1990 until this day, that's not an entitlement program like Medicaid. It has to be an appropriation every year. And every 5 years, it has to be reauthorized. And it successfully made reauthorization and sometimes increased appropriations every year and every 5 years since the beginning of that program. Activists were involved in writing the language of the legislation. The two main people at the time that pushed that was Congressman Waxman in Los Angeles and Senator Kennedy in Massachusetts. The main drivers of that legislation, and activists sat there with them in writing the legislation. And the last thing I want to say about activists with this, which is I think really important, is that activists pushed for a different approach with clinical trials. So the gold standard was a control group gets nothing, or something masking itself as something, and the experiential group gets the actual experiential medication. The activists associated with the HIV pandemic said, oh no, we're not going to have people dying with a placebo, which is what that's called. It's going to be your experiential medication versus whatever the standard of care is available and approved at the time. And that has pushed the nature of clinical trials, not just for HIV, but for all kinds of health conditions. So activism has meant a lot insofar as getting this far. And the last thing I want to say about activism, and this is on the global scale, is what, like I said, in 2000, 5 years after the medications were proven effective, in 2000, only 8% of the people in the world living with HIV had access to these antiretroviral therapies. But global activism pushed the pharmaceutical companies, pushed President Bush at the time to start PEPFAR. And then I think the Bill and Melinda Gates and the Global Fund for TB, HIV, and malaria was started. And that's what got it to the 25 million people on medications today. That's all because of activism.
Well, speaking of activism, let me ask you all this. I need both of you all to be an advocate to talk about the importance of contact tracing and how it was used in HIV as well as COVID-19, and the importance of making sure we have funding to develop and utilize future contact traces. Mm-hmm. So can you all touch on that for us? Because people think this contact tracing is some new term that just came out and should go away now that we have vaccination for COVID.
I'm so glad you brought that up, because one of the things I think everyone should have a deep appreciation for is the name that I know are disease intervention specialists, DIS workers. And if you think about the role that they play around the country, it's incredible. You know, that's how partner services takes place. Excuse me. I'm so sorry. That's how partner services takes place. That's how new people get identified who need services, who need to be tested. And this is, when we talk about the underfunding of public health infrastructure, this is a key area where it's been terrible underfunding for years. And now, you know, contact tracing. But you have experts in this area. And they are, they can train the new people for the future, but that requires an investment that's ongoing, that can be built and sustained, not just with one disease. Expertise can develop with many. So my concern is this is being treated as some part-time, temporary community health worker type thing, when in fact these should be real jobs with real respect, because these are difference makers in terms of taking care of the public's health.
And as a matter of fact, what it's not that what was proposed was wrong, but when you talk about contact tracing in this kind of COVID disease where disease is transferred person to person, that's just one narrow aspect of what these disease intervention specialists do. Let me give you another example that goes on every day, but it doesn't go on enough. We screen children for lead, and any amount of lead in the body is bad for you, let me just say. But when we reach these children that have discoverable lead in their body, what we should be doing is finding out how the lead got into their bodies. But the funding has been cut. So the reality is most places in the country, we don't do that. But if we did, let's say you have a 2-year-old with lead level, maybe your house is okay, but maybe grandma's house is where the lead came from, or somewhere else is where the lead came from. So where we don't follow up on these disease and investigate what's going on and try to make sure that other people are not at risk, then we really fall down on our job. So you're absolutely right. Contact tracers are a basic part of our infrastructure. That's not a word that I like to use. I like the disease interventionist better because they can titrate what they need to do. The second thing I want to say is when you have a forest fire raging, the contact tracing isn't really critical there. What you need then, so when the ICUs were filling up all around the country, what they needed was not contact tracers. They needed people to make sure people could get their food, to make sure people could get to the hospital and that kind of stuff. But those are the same people with the same training. And then as things slowly die down, then you have a contact tracer to chase down and catch the next person before they get infected, in this case with COVID. One last thing I want to say, I know we're running out of time. I want to remind people what Mildred said earlier, being connected with people's movement. So when people are out in the streets about George Floyd, when people are worried about their mental health centers being closed down or the local hospital being closed down, this is something that public health professionals have to pay attention to. Dr. Fauci, who most people in the United States, including me, thinks is a fine public health leader. I think his performance in COVID has been outstanding, especially considering who was the president for most of this pandemic. But in HIV, he was being beat up by ACT UP and the HIV activists. He was a young scientist then, and they were whipping his head in the press and everything else, saying, you're not doing this right. You're not doing the clinical trials right. You don't, remind you now, he's a world expert in this area. But the difference is he learned from working with the movement. He listened to the patients. He listened to the communities that they came from, and he adjusted his scientific methods to address those concerns. So now we talk about community-based research, but really it means treating people with respect, listening to the communities and groups you're working with, and working with them, not making a decision, oh, I'm going to do it this way, but actually bringing them into this process. So I will give him as an example of an excellent world-class scientist who actually listened to people in the streets, I mean, literally in the streets, demonstrating and throwing blood and stuff, and adjusted his scientific methodology, didn't make it less scientific, but adjusted his scientific methodology, as some of my Native American friends call decolonialize the methodology, and he is a much better scientist for doing that.
Well, I'm going to tell you, I learned a lot today. I always learn a lot with Doc Williamson, special person to me. So before we close it out, we always like to go around and let you say some final words. So Doc Williamson, say anything you want, your final words, thoughts for today.
I must say, I'm very much thankful for being a part of this evening's topic. I'm glad you brought this up. I do want to say there are 2 books that came out recently that I just would like to share if anyone is interested in some of the history. One is called Let the Record Show, The Political History of ACT UP by Sarah Schulman. And the other one is called AIDS Pandemic, The Untold Story by Dorothy Cavill. Both of those books just came out, in line with the 40-year anniversary. And if anyone is interested, there's a nice article about Let the Record Show in the current issue of the New Yorker. And once again, I thank you all. I remain passionate about this issue, in these 40 years. So thank you.
Doc Murray?
I want to thank Mildred for joining us tonight. This is an important milestone. And I want us to be in a position where 40 years from now, we're not having is not having a podcast about COVID-19 or 20 or 21, whatever we call it then, still causing havoc in our community. So there are lessons to learn from the HIV pandemic. And so I invite people to look at those books. Time is an important and interesting thing. And last, this is completely irrelevant, but I want to do a shout out to my baby boy, Mr. Murray, for becoming 50 years old on Monday. So congratulations, son, on your big day. And please join us next month, the third Wednesday of each month.
51, but that's another story. Thank you. And I just want to acknowledge something. You know, right now there's a thing going around giving people flowers. I'm an old school guy. I'm a man. I'm a warrior. I'm a general. I don't give flowers. Flowers die. I give medals. But I want to acknowledge Andre Moore. You know, a lot of times you see Dr. Murray and myself and our established guests on here, but without brothers like Andre Moore, none of this shit would happen. Like, Andre does excellent things even outside of this. I want to acknowledge he made the Dean's List at UIC. You know, it's rare that people acknowledge Black men for their accomplishments. I think he would have had all A's. Some corny ass teacher gave him a B based on some group projects of the way they grade, but that's a whole nother story. I'll let them fight that. But that's important because and the teacher was Black too. So just because you look like us don't mean you forced. The reason that's important, Andre plans on going to attend medical school or law school. That GPA changes a lot of things, you know, with scholarships, entry, and everything. So you little undergrad teachers that are hard on us Black folks and don't honor us for our opinions, y'all messing with our future. And us health professionals are going to take these brothers back, and we're going to come for your head. So just be careful. But again, thanks for tuning in. Every third Wednesday, next month, we're going to have some good things. Thanks to Dr. Williamson, Dr. Murray, and always thank you, Jay. Peace. We'll see y'all next month.
Thank you.